Preeclampsia is a syndrome characterized by elevated blood pressure that occurs after 20 weeks of gestation. The elevation in blood pressure can be with or without protein, and in the severe form, usually we have end organ damage. As health workers, we have the mandate to recognize preeclampsia in pregnant women because these women come to us during antenatal. So the routine checks that we do during antenatal will bring out preeclampsia early enough. Of course, that's on condition that mothers attend antenatal early. So when the mothers come to us, ideally, among the many checkups that we do blood pressure measurements. Usually, preeclampsia develops after 20 weeks of gestation. So if you have this mother before you that has exceeded 20 weeks of gestation or is thereabout, and you take their blood pressure and it exceeds, the systolic exceeds 140 or the diastolic exceeds 90, that mother could have preeclampsia. So for mothers who have that elevated blood pressure, but the systolic is below 160 and the diastolic is below 110, usually you want to do urine protein for those mothers, and they would have urine protein of 2+ or a protein quantity of more than 300 milligrams in a 24-hour sample. That is not to say that you cannot diagnose preeclampsia if there's no urine protein. There are mothers who present to you and they have blood pressures exceeding, the systolic exceeding 160 and the diastolic exceeding 110. For those patients, you do not need urine protein to diagnose preeclampsia. And in addition to urine protein and then this high blood pressure that's within the severe range, like we shall look at the severe features later, they could have signs and symptoms of end organ damage. Preeclampsia, like we said, usually it is a syndrome characterized by high blood pressure and these other symptoms we've talked about. So it's a multi-system disorder. It basically affects all the body systems, but majorly it affects the brain, it affects the lungs, it affects the heart, the liver, the kidneys. So these mothers may present you with symptoms in the central nervous system like severe persistent headache. They may have altered vision. They may have double vision, blurred vision, or seeing bright lights where there is no light at all. If a mother presents you with any of those symptoms, you may want to suspect they could be having preeclampsia, in addition to the high blood pressure we already talked about. Mothers who are at risk of preeclampsia, these include mothers who already have pre-existing conditions that compromise the cardiovascular system, and these conditions include cardiac disease, for example, myocardial infarction. If mothers have high blood pressure that is already chronic, they are at high risk of getting hypertension. If the mothers have some autoimmune conditions like antiphospholipid syndrome or systemic lupus erythematosus, those mothers are at risk of getting preeclampsia. Mothers who have chronic kidney disease, they are also at risk of getting preeclampsia. I already talked about diabetes, both type 1 and type 2 predisposed. Then we have a category of mothers in whom the placental mass is increased in pregnancy. This includes mothers still with diabetes mellitus, but also mothers who have multifetal gestations, talk about the twins, the triplets, the quadruplets, and higher order gestations, and mothers who have hydatid form molar pregnancy is another risk factor that predisposes these mothers to pregnancy. Then we have mothers who have personal risk factors. Take, for instance, a mother who has a mother that got preeclampsia or who has a sister that got preeclampsia. That mother is at an increased risk of getting preeclampsia. Then mothers who had preeclampsia in the previous pregnancy, especially those who had early onset preeclampsia and then got a bad outcome during the pregnancy. Take, for instance, maybe premature labor, stillbirth, abruptio. So those mothers are at a higher risk of getting preeclampsia. So how does preeclampsia develop? The pathophysiology of preeclampsia is still elusive, but we know that mothers who get preeclampsia, there is poor invasion of the cytotrophoblastic cells to the maternal spiral arteries. So what happens in normal pregnancy is that cytotrophoblastic invasion of the maternal spiral arteries begins in the late first trimester and is completed about 18 to 20 weeks. So when the cytotrophoblastic cells invade the maternal spiral arteries, usually the maternal spiral arteries are low caliber, high resistance vessels, and you know that it reduces blood flow through them. So what happens in preeclampsia in normal pregnancy is that these spiral arteries are invaded by the trophoblastic cells, and this changes the high resistance low caliber vessels to low resistance large caliber, hence facilitating flow of blood to the placenta and the baby. However, this invasion in preeclampsia is defective. It does not happen the way it happens in normal pregnancy. So what happens is that the spiral arteries, which are supposed to be low resistance, remain high resistance, hence impeding flow of blood to the placenta and to the baby. This causes release of inflammatory mediators that can trigger the whole cascade of preeclampsia. So we have placental hypoperfusion because of failure of invasion of the spiral arteries, and this causes a state of hypoxia and then ischemia. So we have release of mediators that bind the vesicular endothelial growth factor and the placental growth factor, and this triggers vesicular injury and systemic inflammation. This is basically what causes the way preeclampsia presents. So it is important that once you make the diagnosis, you need to intervene timely, because as you see, the ischemia becomes progressive. As the placenta is becoming larger, the blood supply is low, so the ischemia can become worse. So that's why it is important that we intervene timely when we make the diagnosis. There is an element of postpartum preeclampsia. The mechanism is not very well understood. However, there could be delay in clearance of the anti-angiogenic factors. There could be activation of the complement system, and also after delivery we could have movement of water from the extracellular component back into the intracellular component, and that can increase blood pressure. So there is a possibility of developing preeclampsia in the postpartum period. Currently, preeclampsia is classified as preeclampsia without severe features and preeclampsia with severe features, replacing the old classification of mild and severe preeclampsia. So looking at preeclampsia without severe features, these are mothers that present to us and they have high blood pressure after 20 weeks of gestation in the range of the systolic in the range of 140 to 159, and in the diastolic in a range of 90 to below 110. So if a mother presents and they have this blood pressure, high blood pressure, then you want to take it a step further and investigate to see actually if they have preeclampsia. So if these mothers have a urine protein, we said, of +2 or a urine protein of more than 300 milligrams in a 24-hour sample, these mothers have preeclampsia without severe features. These mothers do not have any signs and symptoms of end organ damage. So that is how we classify the preeclampsia without severe features. So for preeclampsia with severe features, these mothers present with a blood pressure that's 160 and above for systolic or 110 above for diastolic. That is enough to put a mother in the category of preeclampsia with severe features. However, if a mother has any of the blood pressures that's above 140 systolic and above 90 diastolic, and they have signs and symptoms of end organ damage, then they are in the severe category. What are these signs and symptoms that we are calling the severe features? If a mother presents with Signs in the central nervous system, the mother has severe persistent headache that may be unresponsive to painkillers, and they have this pressure we've talked about. This mother has preeclampsia with severe features. If they have visual disturbances, double vision, blood vision, if they have photopsia, they are seeing bright lights while there's actually no lights, if they have visual scotomata, that mother will also have preeclampsia with severe features. In the gastrointestinal system, usually these mothers present with severe epigastric pain. So if these mothers have severe epigastric pain, unlike the pain that we see in normal pregnancy due to gastritis, these mothers, coupled with, of course, the blood pressure, these mothers also have preeclampsia with severe features. Then we have, they could have nausea and vomiting. That can also be a feature. So in the gastrointestinal system, if these mothers have elevated liver enzymes, and here we look at usually AST and ALT, aspartate and alanine aminotransferases. Usually in preeclampsia with severe features, these enzymes are markedly elevated, and we look at them doubling, usually the upper limit. So if you get deranged liver enzymes in that category, then you want to categorize this mother as preeclampsia with severe features. In the genitourinary system, the kidneys also are affected, and we have elevated creatinine, and we look at creatinine levels above 1.1 grams per deciliter, or more than 90 micromoles per liter in these patients. Then they also have a reduced urine output due to the kidney damage, and we look at urine output of less than 0.5 mils per kg, or quantitatively if they have less than 120 mils in 4 hours or 30 mils per hour. Then that mother also may have really progressed to the severe category, and these are mothers you want to intervene immediately. Then in the respiratory system, this patient usually develop pulmonary edema, and usually it presents as oxygen saturation that's less than 90% on room air. And usually this comes with a difficulty in breathing, the increased respiratory rate. So if you have a mother with this feature, this mother also you want to intervene immediately. Then we have the hematological system. We have the blood itself. It also gets derangement. So here we look at the platelet count. It goes below 100,000 cells per microliter, and we could have hemolysis, and this can point to preeclampsia with severe features. So there is a syndrome, usually a triad called HELP syndrome. So HELP syndrome is a triad of hemolysis, elevated liver enzymes like we talked about, and then the low platelets. The platelet count, we are looking at the platelet count of below 100,000. So these are some of the severe symptoms. If a mother presents with blood pressure of 160 systolic and above, or 110 and above, without any of these other symptoms, then that mother also is categorized as preeclampsia with severe features. Other features of preeclampsia with severe features, these include yellowing of the eyes. The mother presents with yellowing of the eyes, and we've looked at hemolysis, one of the triad of HELP, and that is where that comes from. We could have acute liver failure, and that can present with yellowing of the eyes. Then these mothers, we have the normal edema of pregnancy, but in preeclampsia, you have excessive edema. So what does that mean? You may not be able to tell what normal edema is, what excessive edema is. If a mother presents you with edema, you basically want to be sure that it is preeclampsia. Take the BP, and if it's suggestive, go ahead to do the labs to rule out preeclampsia.